So this is part 2 of the video PowerPoint on pain. So I really don't understand this mechanism that involves the reticular formation, and it's just kind of a curiosity. But apparently, when there's a lot of input from stimulating influences of pain, like excessive sensory input, the brain is able to cause the patient to be able to ignore or become unaware of the pain. We've all heard this happening where there will be a significant motor vehicle accident and the patient does not feel pain initially. So that's just an interesting phenomenon. So we're going to get down to the nitty-gritty and start to address our patient. First, assessing their pain. I agree that obtaining a complete pain history is important, and of course nonverbal signs of pain are important as well. But for me, when I go into a patient's room, usually post-surgically or in a pain situation where they have been assessing their pain for some time, it is more important to try to speak their language when you're having them assess their pain. Find out what has worked for them. Find out if they're happy with their pain relief. Find out if they have any concerns. Talk to them about the importance of treating their pain, but also the importance of mobility and healing and getting beyond the point of needing pain medication. Share with them what appropriate or usual pain medication treatment includes in your experience with other patients similar to them. So remember to assess pain as your 5th vital sign. So in the patient room, after I have established rapport with the patient and attended to their immediate needs and concerns, I ask them, how would you rate your pain? Sometimes people find 0 to 10 to be overwhelming, and I'll switch to mild, moderate, or severe pain. And I'll also ask them, so what level is appropriate or is tolerable for you? Where would you be satisfied with your pain being? And we try to aim for that number. And many times patients will say 1, 2, or 3 is fine, but above that they start to want medications. There's also the pain scale that has different expressions of smiley faces that you can have the patient identify. So the recommended clinical approach to pain assessment is to ask about their pain regularly. It is your 5th vital sign. Trust that the patient is doing their best to rate their pain for you. Know what drugs, doses, and at what intervals to give to balance pain control with the adverse effects of respiratory depression. Please go to page 1166 and examine the content in box 32.4, especially the side effect of respiratory depression. Follow up after you intervene for pain and document the response to the intervention. By teaching the patient and family what to expect and giving them a plan where they are an active part, you are increasing the quality of your care. Nights and evenings are often worse for patients. Try and anticipate needs and make the calls you need early in your shift for changes in pain medication orders. Listen to this situation. You are assessing an older adult experiencing intense acute pain related to a hip fracture. Her health record includes documented abuse of prescription narcotics. 1 hour after receiving the opioid dose, she is moaning loudly in pain while rattling the bed rails. She repeatedly calls you for more pain reliever, even though you have already administered analgesics as prescribed. What might you assume is going on in this situation. It's very easy to label a patient as a drug seeker or someone with a substance abuse problem. But it's complicated because the healthcare provider might be uncomfortable asking questions about alcohol and illicit drug use, and there may not be a thorough assessment of past history. And so in order to provide a good pain management program for the patient, it is important for the physician to have gathered substance abuse history. She could also have developed a tolerance to the opioid and need higher doses. Of course, nurses are going to be fearful of overdosing and either causing side effects or contribute to narcotic addiction. Healthcare providers might not have provided sufficient non-pharmacological therapies as an adjunct to opioid pain relievers. So there might be some other things such as ice or elevation or distraction or taking care of her emotional needs in other ways, her fears, to help. So the elderly, it's common for them to have persistent pain from degenerative spine conditions, arthritis, nightly leg pain, or as a result of cancer. Older adults are at risk for undertreatment of pain because they and their caregivers may be reluctant to administer analgesics for fear of producing confusion, excessive sedation, drug interactions, and respiratory depression. There's a risk of overtreatment due to the higher peak effect and longer duration of pain relief that they experience as a result of the changes associated with aging, such as decreased renal function, decreased liver function. Poor pain management can actually result in falls, poor sleep, delayed healing, reduced activity, and prolonged hospitalizations, and overall a poor quality of life. Clients that have addictions. Addictions is a state of psychological dependence in which a person uses a drug compulsively and will engage in self-destructive behavior to obtain the drug. They actually have changes in their brain. Many studies have shown that the properly managed short-term medical use of opioid analgesic drugs is safe and rarely causes addiction. Those with a personal or family history of drug abuse or mental illness are at greatest risk for abusing opioids. Older patients that have dementia are extremely difficult to assess. This is a validated tool called PainAid that helps in finding out if a patient has pain or not that has dementia. There are 5 specific indicators: breathing, vocalization, facial expression, body language, and consolability. The total scores range from 0 to 10, with higher scores indicating more severe pain. For each of the 5 rows, determine the score 0, 1, or 2 based on the presenting behavior. The score is expressed as the total out of 10, such as 6 over 10. I found comments in the research saying that a score of 3 to 4 requires intervention for pain. Knowing the patient makes assessing more accurate. I had a nursing student last semester that talked to me about taking care of her father in the last days of his life, and how even though he was no longer speaking, she could tell when he was in pain. So sometimes family members can be wonderful sources of information because they have observed that person for so much longer than you have. So the nurse is assessing the confused patient. In trying to determine the client's level of pain, the nurse should Be aware that confused clients do not feel as much pain due to their confusion. Observe the client carefully for changes in behavior or vital signs. Ask the client's family how much pain the client normally has. B. Use only pain scales that feature numbers or faces that the client can point to. The best answer is B. C would be a correct answer, but not as good as B. There are many nonverbal signs of pain. Look at their facial expression, their posture, the way they move, changes in vital signs. But note that normal vital signs do not mean that the patient is free of pain. Patients may be in pain even if they don't act like they are. Of course, if they speak a different language, you need to provide an interpreter. As I said earlier, some patients feel that they are bad or weak if they express pain. Such patients may withdraw or become stoic. It is important that you establish a trusting relationship with them. Convey your concern and acknowledge the person's pain. If the person trusts you, he or she will feel free to verbalize thoughts and feelings. Depression is often overlooked in the patient in pain. So now we're to the nuts and bolts of pain management. First, we will cover the non-pharmacological measures. Cutaneous stimulation. There's many ways you can do this. Starting from the bottom, you can stimulate or rub the opposite side of the body that is in pain. You can use heat or cold. Of course, there's safety measures that you need to pay attention to the skin when you are applying heat and cold, and do it for short periods of time at intervals. Massage or effleurage is a wonderful thing to do for someone in pain. We already talked a little bit about acupuncture and acupressure. Stimulating nerves or the spinal cord are excellent ways to use the gate control theory to lessen pain sensation or perception. There's the TENS unit, PENS unit, and the SCS. The spinal cord stimulator is, of course, a surgically implanted stimulator, and the percutaneous goes through the skin, but the needle probes to stimulate peripheral sensory nerves, whereas the transcutaneous or the TENS unit consists of electrode pads, a connecting wire, and a stimulator that's outside of the patient's body, just put on with stickers. Oral sucrose and immobilization are two other methods of non-pharmacological measures. It can be effective for pain control in newborns exposed to mild or moderately painful procedures. I believe they do this for circumcision. I'm not convinced that it's effective, but I don't know any studies on it. Immobilization. It's especially helpful with arthritic joints, it says here. I think of a cast, immobilizing a body part to help with pain. There are also cognitive behavioral interventions for pain, and the list here is long. This is a picture of an animal coming into the hospital to visit with a patient and provide some pain relief through distraction and just wonderful dog therapy time. I've seen this work so many times. So read over the methods here. These are wonderful additions to your toolbox that you as a nurse can do. So in the medicine measures, we have non-opioids, adjunctive analgesics, and opioids. And we saw that illustrated a little bit in the WHO STEP program for cancer pain earlier in the lecture. NSAIDs, of course, include aspirin, ibuprofen, and several others. They're anti-inflammatory, and they really help a lot of people. Of course, people with kidney problems cannot take NSAIDs, and people with liver problems cannot take acetaminophen. Acetaminophen has very little anti-inflammatory effect, but it does have analgesic and fever-reducing properties. It has fewer side effects as well. It's considered one of the safest drugs. Adjunctive adjuvant analgesics are things like antidepressants, anticonvulsants, topicals, psychostimulants, muscle relaxants, steroids. All of those can really help with pain control. And then the opioids, of course, are things like Dilaudid, which is very strong, fentanyl, morphine. And those can be put into a PCA pump or client-controlled analgesia pump. Teaching is important for the patient to know that the program that you put into the machine will not allow them to overdose. However, there have been many overdoses with these machines, so it is important to monitor what is happening in the room. Sometimes, even though a patient has adequate pain control, the family will push the button and it'll be too much for the patient in time. So it's important to monitor and to educate. Another quiz question. Mr. Zenobia's chronic cancer pain has recently increased, and he asks the home health nurse what can be done. In relation to his long-acting morphine, which is an appropriate response by the nurse? A, if you take more, it will not change your pain relief. B, I'll call the primary care provider and ask for an increased dose. C, the amount you are taking now is all I can give you. Or D, I'm worried if we increase your dose that you will stop breathing. So, of course, the correct answer is B. You need to call the doctor to ask for an increase in dose. There is no ceiling on the analgesic effect of opioid narcotics. Patients develop a tolerance to the effects, which often necessitates an increase in the dose. An obese 65-year-old patient suffers with chronic back pain due to a herniated disc that developed after a motor vehicle accident. How might you help him achieve better pain control? So there are many ways that you could attack this problem. Can you think of some without looking at the answers? So there's a variety of methods. Maybe hot or cold therapy, maybe exercise, maybe medications, maybe alternative medical solutions such as chiropractic, soft tissue massage, active release therapy, TENS units, acupuncture, acupressure, surgery, such as spinal fusion, laminectomy, foramotomy, discectomy, disc replacement, and interlaminar implant, or patient teaching, instructing the patient how to lift, pull, and push with less stress on the back. You can modify the way he moves. Eating a healthy diet and not smoking also helps. Pain clinics are places that treat clients on an inpatient or outpatient basis. It is multidisciplinary. Physical therapists, occupational therapists, psychologists, massage therapists, social workers, nurses, doctors, surgeons may all be part of the team to treat pain. There are more invasive types of pain relief available that we will talk about now. Some of these are not that invasive. Nerve blocks or epidural injections are types of regional anesthesia. It is possible for them to not work in one patient as well as others, and it could also be due to the skill of the anesthesiologist. Local anesthetics, such as short-acting lidocaine or longer-acting Marcaine, can numb areas of the body and be helpful in procedures. Topical anesthesia is sometimes used to relieve mild to moderate pain. Some last-ditch efforts often used in cancer is radiofrequency ablation. Radiofrequency ablation therapy uses electromagnetic waves that travel at the speed of light to target nerves that carry pain impulses. This procedure is used to provide longer-term pain relief than that provided by injections of steroids, analgesics, and nerve blocks. So this is a picture of a radiofrequency ablation. And surgeries can interrupt pain conduction pathways. A cordotomy interrupts pain and temperature sensation below the tract that is severed. This is most frequently done for leg and trunk pain. Rhizotomy interrupts the anterior or posterior nerve route that is located between the ganglion and the cord. Anterior interruption is generally used to stop spastic movements that accompany paraplegia. Posterior interruption eliminates pain in the area innervated. This procedure may be safely performed at any level along the spine, but is most often used for head and neck pain produced by cancer. Neurectomy is used to eliminate intractable localized pain. The pathways of peripheral or cranial nerves are interrupted to block pain transmission. Sympathectomy severs the paths to the sympathetic division of the autonomic nervous system. This procedure is performed to improve vascular blood supply and eliminate vasospasm. It is used to treat the pain from vascular disorders such as Raynaud's disease. Surgical therapies disrupting pain pathways are not widely used because of advances in oral and transdermal opioid therapies. Managing postoperative pain. Make a note of the 6 points in this slide for a class activity. The subject of placebos is can be very controversial and ethical dilemma. This is any medication or procedure, including surgery, that produces an effect in a patient because of its implicit or explicit intent, not because of its specific physical or chemical properties. It is not well understood why placebos can relieve pain for some patients. Theories include operant conditioning, faith, anxiety reduction, and endorphin release. The Oncology Nursing Society position, endorsed by the ANA in December of 1996, states that the position that placebos should not be used to assess or manage cancer pain, to determine if the pain is real or not, or to diagnose psychological symptoms such as anxiety associated with pain. Nurses should not administer placebos in these circumstances, even if there is a medical order. Of course, this is an old position statement, but I have read lately that placebos can be unethical except in controlled environments where a study is being done and the patient has agreed to the study. So review your outcomes, remember what we have talked about, and I will see you in class.